Hey, it's Beth again. I'm providing you a podcast for Chapter 30, Unit 3, NUR 136. And these drugs are going to be the ones that decrease histamine effect and the allergic response. So, we got to talk about the body's response to inflammation. And in the beginning of this unit in Chapter 10, we talked about the immune response. Now we're going to talk about the inflammatory response, and these work together for sure. So it's interesting that we the whole body's response on the inflammatory response is just amazing. And let's just start talking about it. The inflammatory response is when tissues are injured by anything, bacteria, trauma, toxins, heat, or any other cause. And these damaged cells then release chemicals including histamines, bradykins, prostaglandins, and these chemicals cause the blood vessels then to leak into the tissue, and that causes the swelling. It also helps isolate the foreign substance from any other contact with the body tissue. Now, the chemicals also attract white blood cells called phagocytes, and they eat microorganisms and dead or damaged cells. So I kind of think of them as our Pac-Man on the game that used to be out there. And this is called phagocytosis, and phagocytes eventually die. Then we have pus that's formed from a collection of the dead tissue and the dead bacteria and live and dead phagocytes. And then a fever is produced as a result of the pyrogens affecting the hypothalamus. So that's what goes on in that inflammatory process. And we got to think about it and try to simplify it. We get injured, the blood vessels respond, have an accumulation of fluid and white blood cells. And, again, thinking about that whole inflammatory process, it's a good thing when we're injured. But it is also the part of the process that causes us pain and swelling and redness. And we're going to focus on this unit, the histamine's role in the inflammatory process. Actually, to date, there are 4 types of histamine. They refer to them as H1, H2, H3, and H4. But for this unit, we're going to focus on the histamine 1, H1. So, what are histamines? What in the world are these things that we're talking about? They are the first chemical mediator to respond in the immune and inflammatory response. And when we think about mediator, that word, chemical mediator, a mediator is something that helps things meet the middle. It helps things resolve conflict, and so these chemical mediators are meant to cause a positive thing, although we know that it's they could cause things that aren't so positive either. Okay, so they're synthesized and stored in the tissue, found in the central nervous system, and they are secreted from mast cells, which are tissue cells surrounding capillaries, and basophils, which are a type of leukocytes. Or a type of WBCs, or leukocytes, yeah. And they're also known as granulocytes. But it is released in response to the inflammation, also extreme cold and allergic reactions. And when it's released, when histamine is released, it binds with the H1 and H2 receptors. So we have this chemical mediator, histamine, that's released, and then it has to attach to receptors on target organs, and specifically H1 and H2 receptors. The H1 receptors are on the smooth muscle cells in the blood vessels and the respiratory tract and the GI tract, the gastrointestinal tract. What happens after the binding to the H1 receptors is contractions of the smooth muscles in the bronchial and bronchioles, which causes bronchial constriction and respiratory distress. It stimulates the vagus nerve endings to produce bronchoconstriction and cough, and it increases the permeability of the veins and capillaries, which allows the fluid to flow in that subcutaneous tissue, and that then forms the edema. Increased secretion of mucus glands and also happens, and stimulation of sensory peripheral nerve endings that happens, and that causes pain and pruritus, which is itching. Dilation of capillaries in the skin happens, and this will cause flushing. Now, the H2 receptors primarily affect the GI tract, the gastrointestinal tract. So, is the following true or false? Histamine is the first chemical mediator to respond in the inflammatory response, and I know you answered true to that because you were listening to the previous slide. Okay, so what goes on when we're having a hypersensitivity reaction? Allergic reaction is another way to say this, but what happens is our immune system is overworking. It's an exaggerated response that produces tissue injury and can definitely cause serious problems for sure. So, again, the immune response is a complex part of the body, but I think it's fascinating. When the body becomes exposed to an antigen, then it recognizes it as an antigen and begins working to get rid of it. It forms the antibodies and has the T cells to remember this antigen, and it keeps it in that memory in hopes that it will come back again because it will take care of it if it does come back again. So for future exposures via that inflammatory response. Allergies to specific things causes the immune system to work overtime, and that's when we say it's a hyperimmune system, and thus the hypersensitive immune system is considered the hyperimmune system. Again, the inflammatory response is a good thing here, but it's what causes that tissue damage and other signs and symptoms, and can eventually or sometimes be an anaphylactic reaction, which can lead to death. So, types of responses to cell-mediated invasions. Okay, basically what we're meaning here is that the cells are invaded. And so here's the types of things. These are grouped according to producing mechanisms. So we have type 2, 1, 2, and 3 with the antibody immunoglobulin molecules, and type 4 is an antigen-specific T cell. So let's get into it. Type 1 is an IgE, antibody-induced response, and that is where we can get or have anaphylaxis, which is a deadly type of allergic response, and that occurs on second exposure to an antigen. Let's say that we're allergic to penicillin. So what has to happen there is some type of exposure to penicillin had to have happened initially before we had that anaphylactic reaction. Now, penicillin is made from mold. So we know many times have been exposed to mold. So, you know, think about it that way. That you've got the patients have to have some type of exposure at some point before they have an anaphylactic reaction. Okay, so we're talking about antibodies and these different types here. And antibodies are your immunoglobulins, remember, with your immune system. And there are 5 types of immunoglobulins of IgA, IgD, IgE, IgG, and IgM. Each one of them has a different role in the immune process. Now, the top one that we just talked about that involves the IgE and induced response to antigens. So it causes a release of the mediator. And again, think of the role of the mediator, which is someone that resolves or settles something, working with those conflicting parties there. And so it releases the histamine. And other things, cytokines and chemokines and leukotrienes to help with that whole immune response. Now, anaphylaxis is a type 1, and you can have a mild reaction such as urticaria, or you can have a severe one which causes shock, laryngeal edema, bronchospasms, bronchoconstrictions, respiratory distress. It also causes mass vasodilation, and that causes severe hypotension, and the person can have a cardiovascular collapse. This is where epinephrine is going to be used, which is an adrenergic agonist, and we will also use antihistamines to block the production of the histamines, the response of the histamines. Type 2 is mediated by IgG or IgM, and it will generate a direct damage to the cell surface. This can happen with blood transfusion reactions. So if a patient is having to receive blood for whatever reason, maybe anemia, or they've lost blood in surgery, or they've lost blood from a car accident or something like that, they can, receive someone else's blood and actually get, or have a blood transfusion reaction. So blood transfusions are pretty risky. Also hemolytic diseases, which is of the blood and the red blood cells where they are diseased, and thrombocytopenia, which is where the platelets are very low. And this can actually be an adverse effect of certain drugs. So that's why it's important to read about your drugs to see if, in fact, it can cause a type 2 reaction. All drugs can cause a type 1 reaction, but certain drugs can cause this type of reaction. Then we have a type 3 reaction that can happen, and that's mediated by IgG or IgM. And this is where this type of reaction forms an antigen-antibody complex. And so the antigen antibodies kind of form together, literally form together, these complexes, and they clog up the system, if you will. Those complexes do, and it causes major inflammation in tissues. So you might see this like in the kidneys, where these complexes form and they deposit into the renal tubules and clog up the system and cause major inflammation. So that's when we have too much of the antibody or antigen-antibody complex deposits in the vessels, then that's when you're going to see that inflammatory reaction occurring. And eventually or can damage the vessels. Now, serum sickness is an example of this as well. That occurs around 2 to 3 week period after exposure to a drug. So, when patients come in and we don't know what in the world's going on with them, we need to ask, what have you done different here? And, you may find out, hey, I took this drug for whatever, 2 or 3 weeks ago, and, it in fact may be that serum sickness. Type 4, also known as a delayed hypersensitivity reaction, and that's a cell-mediated response. We have the synthesized T lymphocytes reacts with the antigen to cause the inflammation, and this can be your TB test, contact dermatitis, which is the skin, where the skin has repeated exposure. An example of that is latex. Okay, so a lot of people, healthcare workers particularly, have become allergic to latex because of repeated exposure to that. With the skin, and they react with the contact dermatitis. And then graft rejection is like an organ donor. If someone donates an organ and gets an organ, the recipient can have this type of reaction to it. A graft reaction can happen to anything. Burns that have repair with grafting done, they can have a reaction to that as well, and a rejection. So, question, there are 4 classifications of hypersensitivity reactions that exist, and hopefully you've answered yes. So just a quick review. Type 1 is an immediate response that happens to the body. Type 2 is direct damage to cell surface. Type 3 is the formation of antigen-antibody complexes. And type 4 is a delayed hypersensitivity. Okay, so what goes on when we get an allergic reaction? So these are some of your minor symptoms. Inflammation of the nasal mucosa because we've inhaled an allergen. And so we're going to see nasal congestion, itching, sneezing, watery drainage, and itching of the throat, eyes, and ears are common. 2 types of allergic rhinitis. So we can have seasonal type, which is like hay fever, where folks respond to airborne pollens, and the perennial diseases that responds to non-seasonal allergens such as dust mites, molds, trees, things like that, animal danders. So what happens to cause this? The person is exposed to the antigen, the body learns the antigen and builds up the antibodies. The next exposure, antibodies attack but also release the histamine and other inflammatory mediators. The histamine engorges the blood vessels to produce that nasal congestion and stimulates secretion of mucus, and gets the eosinophils, lymphocytes, monocytes, and macrophages to come to the rescue as well. So we got to turn that histamine off, because that histamine is what's causing us to have issues, and thus that's why we take antihistamines. So allergic rhinitis is caused by type 2 sensitivity. Nope. The answer is type 1. Okay, because it's an immediate reaction. Okay, allergic contact dermatitis is related to the type 4 reaction involving the skin, and that's where, again, we have inflamed, warm, edema, intense pruritus, tenderness to touch. You might see lesions there, erythemosis, which is redness, macules. Macules are flat lesions on the skin. Papules are raised lesions on the skin, and vesicles have fluid in them. Of course, these are, when these are there, they itch, okay? Pruritus is itching. And so with that itching, we have a risk for infection because once the skin is broken, and it can be broken easily with the scratching, then we set up the body for infection, okay? Because anything can get in where the skin is broken. So examples of this is poison ivy, cosmetics, metals, topical medications, and I mentioned to you the latex. Food reactions are also an immune response, and you know, we have a lot of folks that are very allergic to certain foods, shellfish and corn, seeds, bananas, eggs, soy, peanuts, tree nuts, and you know, they can trigger an anaphylaxis. Children can be allergic to milk, eggs, soy, wheat. They may actually outgrow them, and you know, they're trying new things about sensitization of allergies to with kids especially, to different things. Saw something on that in the news. Okay, so allergic drug reactions. Suspect if we have new signs and symptoms that develop or if they're different from the disease process. If it follows the ingestion of a drug. If it occurs after 7 to 10 days, and that's what it takes the time for antibodies to form. If it follows a previous exposure to the same or similar drug. If the signs and symptoms aren't those of known adverse effects of a particular drug. And if the signs and symptoms are those of an allergic reaction, like urticaria, difficulty breathing, bronchospasms, those kinds of things. If there is an increase in the eosinophils of a WBC, a white blood count, and you'll see that on lab work for, it comes on the complete blood count, CBC. You can look for the WBCs, and you'll see the eosinophils in a differential CBC. If you see signs and symptoms resolve after stopping the drug. So, extremely important. If you suspect a drug reaction, you want to stop the medication. That's going to be crucial. That's going to be the first thing you do. If it's going IV, you're going to stop that drug. Okay? Because if you don't stop it, it's going to keep going, and we're going to, you know, have continued problems. So, anaphylaxis can occur with any drug. Serum sickness is seen with antimicrobials, initial exposure to antigens, and we can see that within 7 to 10 days. Urticaria, lymphadenopathy, which is your lymph glands basically are swollen. Myalgia is muscle pain. Arthralgia is joint pain, and fever. This has to be treated because it can be fatal. Systemic lupus, drug-induced type, can be due to hydralazine, procainamide, and isoniazid. These are specific medicines. The first two are cardiac drugs, and then the last one is for tuberculosis. Signs and symptoms of that is fever, skin lesions, pneumonia, anemia, arthralgia, arthritis, and nephritis, which is involving the nephrons of your kidneys. And then fever, you may see that with any type of drug reaction. So let's talk about our medications. Antihistamines. Reason we give them is we want to cut off that histamine production. And it is a medication that antagonizes the action of histamine. And we have first generation and second generation meds, okay? Your prototype is diphenhydramine, also known as Benadryl. So that's your first generation H1 receptor antagonist. and it can prevent or reduce most physiological effects of the histamine at the receptor site. So it's going to inhibit smooth muscle constriction in the blood vessels and respiratory tract and the GI tract. It will decrease the permeability of capillaries and decreases salivary and tear formation. Now, these drugs bind with the central and peripheral receptors and can cause central nervous system depression or stimulation, depending on the person. So you may hear about children getting Benadryl, and they are like, you're scraping them off the ceiling. They have it, instead of being sedated, as it does with a lot of people, it's counteracted, and they are hyper as all get out. So not just with children, I've seen that with adults as well. So you can have, stimulation or CNS depression. Indications for use is allergic rhinitis, anaphylaxis, allergic conjunctivitis, which is of the eyes, drug allergies, pseudoallergies, blood and blood product transfusion, and dermatological conditions. So our pharmacokinetics is well absorbed, acts within 15 to 60 hours, and stays in the body pretty long, 4 to 6 hours there. We can get this in any, a lot of different forms: oral, topical, or perennial. It's metabolized in the liver and excreted in the urine. And so again, antihistamines prevent histamine action. And so again, it's going to inhibit the vascular permeability, edema, and bronchoconstriction and pruritus. So we use it for hypersensitivity allergies. It can also be used for motion sickness, because remember, the GI tract is involved with the histamine 1, insomnia, and Parkinsonism. I've not seen it much used there, but I guess it can be. Children, they can have that paradoxical reaction, which I was mentioned a minute ago, where they're, it reacts the opposite way of what we think it will. Overdose of the medicine can cause hallucinations, convulsions, and death. Older adults, very concerning. We got to be careful about using it with them, because it can cause confusion, dizziness, hypotension, sedation, unsteady gait. So right there, we're at risk for falls. If we got an unsteady gait, when we say gait, we mean walk. Paradoxical CNS stimulation, they can, not simulation, stimulation. They can have that just as the child can. Urinary retention, if they have prostate issues, the BPH is benign prostatic hypertrophy, and it has an anticholinergic effect. And we're going to talk about that here in a minute. Anticholinergic effect. Renal impaired, if it's severe, the frequency has to be adjusted, and dose as well. The critically ill, they may receive this prophylactically if getting a blood transfusion to prevent any kind of reaction going on. It isn't recommended for newborns, so we got to be careful about the age population. So adverse effects of CNS depression, cognition, performance impairment. So anytime we give medications like that, we've got to teach the patient about that. We got to teach them that, if they're in the hospital setting, they need to let us know if they need to get up to go to the bathroom, so that we can assist them so they don't fall. It can cause that stimulation too, so we're going to be watching about that. Now, anticholinergic effects. Okay, you're going to see anticholinergic drugs and drugs that have anticholinergic effects, and this being one of them. Okay, Here's your way to remember this, okay? It causes dry mouth, urinary retention, constipation, and blurred vision. These are some common side effects of anticholinergic drugs. So, an easy way to remember that is can't spit, can't pee, can't see, can't, you know what? It goes along with the constipation. So, good way to try to remember that, because that's, when you see that kind of thing, you gotta worry about it. So, when you think about this, okay, would we want to give this medicine to someone who's already got a problem with urinary retention, such as those with prostate problems? Would we want to give this to someone who is already having bowel movement, constipation issues? No. So the other thing is blurred vision, okay? So glaucoma, again, can be an issue. So you see that down in your contraindications. Glaucoma, BPH being your benign prostatic hypertrophy. Also, a narrowing peptic ulcer, stenosing, bladder neck obstruction with the bladder, pregnancy, and of course any hypersensitivity. Drug-drug interactions, look on page 561, box 30-1 for this, or dot 1, I guess. One of the things it mentions is about your MAO inhibitors. You've seen this before with other medicines as well. Don't take within 14 days due to overstimulating the the sympathetic nervous system. Now, if we activate that sympathetic nervous system, what are we going to see? We're going to have somebody that's increased sweating, pupil dilation, blood pressure increase, blood vessels constriction, lung dilation, peristalsis of the digestive tract, increased kidney secretion. So lots of different systems, and if it can act on the cardiovascular system directly there. So we got to be really careful about this MOA inhibitors, because it can really cause some problems there. And those are the antidepressants that we've talked about before. Also, alcohol and other CNS depressants increase the CNS effects of depression. So, we got to be careful about that and teach patients, don't drink while you take this drug. Diphenhydramine also can affect reduce the effectiveness of tamoxifen, which is a anti-cancer drug that's used with breast cancer. Now, you can administer it IM or IV. It's got to be given IV slowly. And if it's used for motion sickness, then you need to take that 30 minutes to 60 minutes before travel. Now, you may have heard of Dramamine that's used for car sickness. That's what that is. That Dramamine is diphenhydramine. So if you've ever had to take that, I had to take it when I was little, and I always thought, well, no wonder they give it to you, because it knocks you out. It puts you to sleep. So anyway. So these are a list of the other first generation drugs. And you can read about those. There's a little bit of different side effects. Some may not cause as much drowsiness as others. So you can read about those in your textbook. Now, your second generation H1 receptors, they don't readily enter the brain from the blood as the others do. Fexofenadine and other drugs in this class bind preferentially to peripheral receptors rather than the central H1 receptors, and that causes us to have less adverse effects. So they've pretty much taken the place of the first generation H1 receptor antagonists in the symptoms of allergic rhinitis and relief of pruritus and urticaria. And they can have a mild beneficial effect for those in with chronic asthma. Here's the thing, though. The second generation medications are typically more expensive than the first generation, like Benadryl. Okay, these are a list of your second generation drugs. So you can read about those. Now the pharmacokinetics, rapidly absorbed, peak in 2.5 hours. So you know, that's a pretty decent time. It's highly bound to protein, and it's excreted in the bile and the urine. 95% unchanged, and it will last 12 to 24 hours, which is pretty good. The way it works is it competes with histamine for binding to histamine receptor sites, thereby preventing activation of the histamine receptors to histamine. So it's used for allergies, urticaria. For older adults, it's much safer than the first generation ones. And for children, it varies. So the products, you got to read about the products to see if it's recommended. And use with caution with renal impaired, because the dose adjustment may need to happen there. Adverse effects is headaches, nausea, vomiting, dysmenorrhea, meaning abnormal period, and fatigue. And of course, it's contraindicated for anybody with allergies. Nursing implications here is we want to prevent those drug-drug interactions and drug-food interactions. We want to administer with water only. We need to shake well any oral suspensions to get it good and mixed up. Oral disintegrating tablets, they need to stay in the package until they're ready to use, or otherwise they will disintegrate. And we need to always assess for therapeutic effects, adverse effects, and we're going to do teaching all the time. So you got to get used to that, doing that teaching. That's why you got to know about the drug. So our nursing process is going to be to assess what current meds they're on, what past meds they've been on in the last 2 weeks, thinking about that MAO inhibitor. What's the purpose of the med and their current medical history, if they have any allergies. If they have allergies, we want specific details. I've had patients say to me, well, I don't want to take this pill because it's making me urinate. I think I'm more than what I'm doing, and I think I'm allergic to it. Well, no, that medicine that you've been put on is supposed to make you urinate more. So that's not an allergy. So you want details about what kind of allergic reaction the client had. Assess prescribed drugs when they report those allergies, and assess the vital signs, the mucosa, what's their urinary status, what's their bowel status, what was the last bowel movement, what's their skin look like, and do they have any kind of lesions or anything like that, and what's their level of consciousness. Diagnosis, we've got risk for injury always because of side effects, and knowledge deficit, and of course compliance can always be an issue as well. And our goal is going to be that they get relief of their symptoms, and that we have safe administration, and that the client has no injuries. So nursing interventions, we're going to assess the baseline vital signs and reassess and make sure that we administer safe, and we're going to do that teaching. That's on page 562, and we want them to increase fluid intake, because remember, can't spit means they're going to have a really dry mouth, so we're going to encourage fluid intake. Evaluation, we want to evaluate that the symptoms are gone and that they have no injuries related to those adverse effects. Okay, this concludes your podcast.